health and psychiatry in the bigger picture and what some of the current trends are, both in the problems and the drivers for people having difficulty in life, and also the treatments that have been emerging that are showing some promise in different areas. What I'm mostly interested in is the big increase in demand that this area has seen, and to tell you guys what we have been up to on this side and the UNSC side to try and be there for the problems and for the people that need help. So as far as Trident goes, we're an HCA hospital. We also have Somerville that we use to serve their emergency department. In 2016, we had 3,200 basically people present for a psychiatric reason to the emergency room. This year, just for the first 10 months, there's already more than 3,400 visits. And there's an additional 1,300 that are coming through the Somerville side that typically funnel in through our system here. We do have inpatient psychiatric beds, but they're always full. They're 100% utilized literally all the time, which is interesting. And they're kind of recent. So the psychiatric beds here have been here for 3 years, is that right? Or a little more than 3 years. Kind of started from scratch after having had them in the past because the need was so high, trying to help the ED and some of the issues that are happening in this area. And we've just kept expanding, which I'll tell you more about later. We also have intensive outpatient programs, and from our ED here, people will go not only to our programs, but to intensive outpatient programs, to community health programs, to Columbia hospitals, the state-operated hospitals, and to MUC sometimes.
So the numbers are eerily similar to Mark's point that through our ED last year we had about 5,500 patients presenting with, and that's with a primary psychiatric complaint, so those aren't even necessarily, and I'm sure it's the same with you all the patients that we're helping to some degree. We have data that folks in the community gather. Our projection, and this is for the tri-state area, so this 25% increase that we expect is what Frank and the company and all will be expecting here as well. So you can do the math and say, as busy as we are now, as many patients as we have sitting in the emergency department now, that will increase, I would say, at least by 25%. That does factor in population growth, but that's a guess. That's by a company that does this for a living and sells data to the hospital. It's SG2 data. It's helpful, but I don't think perfect. So we're bracing for more than that. The other thing we've seen, when I started in my current role about 3 years ago, sirens would go off and everyone would be greatly alarmed if there was one child waiting in the ED for a psychiatric bed. So we have a child-specific unit. On average now there are 4 or 5 kids sitting in the emergency department waiting for a bed. So we knew it was coming. We knew that the adult problem would be a pediatric problem. It is, it's here, and we expect that to grow in parallel really with the adult problem. We operate 100 beds. We track something called the average daily census. That means how many patients are in bed at any given time. When I first started, that number was right around 90. And that just has to do with ebb and flow of children. When they're out of school, they run around and no one notices them being mentally ill, I guess. But when they're in school, they aren't. So our average daily census now is about 97, which means we're basically 100% full. From our ED, and this is a little bit different when I look at y'all's numbers, because you're seeing the same number of ED patients here. You have how many beds to place them in, roughly?
26.
26. I've got 100 beds. So I would say the vast majority of our patients go into our beds when they need them. I'll talk about that, but whereas you have the additional challenge of needing to find beds outside of your own system or within the organization somewhere else. So even more challenging for y'all, for sure. We'll talk a little bit about the other stuff we do as we get into this, but inpatient, what I try to say when I'm even internally at MUSC, inpatient is a small part of what we do. It's a huge operation, but a small part of what we do. And if we do the rest of what we're doing as a community better, then I don't think we'll need less beds, but we won't need as many beds as we're projecting the need. So a psychiatric inpatient bed, absolutely necessary, important business. But really, it's the last resort for a patient with psychiatric illness, and we want to spend a little bit of time talking about what else is out there. One thing we didn't compare notes on, but we actually discharged, out of this 5,500, about 2,500 of those folks were discharged from the ED without being admitted. So we're doing a lot of stabilization within the ED, and then getting them to community mental health, to one of our outpatient programs, things like that. So there's a lot of treatment happening within the ED, for better or worse.
Right, we have the same going here. So we actually have a unit that's not a unit. It's staffed by psychiatry but managed by the ED, called the Behavioral Observation Unit, or BAU. And that can be 10 to 13 people. That's typically pretty full all the time as well. So those patients are not patients. They are actually in the emergency room still, but there's nowhere to go, or we're waiting for the right kind of placement. We actually have doctors, nurse practitioners, and psychiatrically trained nurses and techs that are working to stabilize those people and to get a lot done and discharge a lot that can be handled in that setting. So we have our own sort of kind of quasi-solution here that's not been perfect, but it's trying to meet the need.
Yeah, so just talking a little bit about, Mark said he added some slides in here about some of the stuff that, in psychiatry we're not so proud of, but I think it's important occasionally to take a look back at what we've done and where we're going with things. The brain is the most complicated, I don't even want to say organ in the human body, it's probably the most complicated thing on Earth. If not the universe, if you believe there's things outside of Earth that exist. Trying to be inclusive, I don't know. But billions of cells, trillions of connections. I mean, it is so complex. So, over the years, we understand so much more about the heart, our GI system, and we can look and say, yeah, this is how it works. The brain, we still don't know how it works. We're still learning. That's part of what gets people like Dr. Drummond and I interested in it. But it can be frustrating on the other side, going, well, how do we treat something we don't even know how it's working when it's working right? Mm-hmm. And so we've come a long way. I'll sort of pace myself through these. So, a time we used to just sort of watch people, chain them up when they were manic and psychotic, and say, we don't know why you're doing this, but we know you may harm somebody or somebody else. And we have to understand that's where we're coming from, and that's why we still have serious problems with stigma, with people not wanting to access treatment because they're afraid of the implications of it. Lots of great movies. Everyone know what movie this is? Cuckoo's Nest. Love it. But if this is your impression of what we do in psychiatric hospitals, that's an issue. And people do think that. We have family members come in. They have clearly been dealing with a family member in great distress for many, many, many months, but hesitant to bring them in because they don't want them to be locked up or have their mind numb with medications. And